Chiruatu village in Jharkhand. Breathlessly beautiful and rich in resources, yet poverty stalks every home. Impoverishment has also brought disease to their doorstep, especially pneumonia, which is widespread here. Families struggle with the infection, which is extremely debilitating and in many cases fatal. The most vulnerable are children. Today it appears to be Sumi's turn. Severely malnourished, this 1.5-year-old has had fever and respiratory problems for 2 weeks. Though she's at high risk, her mother is unwilling to take her to the health center.
क्या हुआ है?
पता नहीं।
बुखार हुआ है, क्या हुआ?
हाँ, जार मनता है ये साए करत रहे लेती माटी तेल मन क्या हमरा माई लेली काहे कम पैसा न कौड़ी न कौ तेखन कहाँ ले गई हमरे कई के रात खन बा फर कहलो कि माटी तेल के मां खरसे कई के कहलो.
Lack of awareness often results in families ignoring the signs of pneumonia, and absence of health services increases the risks of fatalities significantly.
नहीं ले जाते हैं कोई यहाँ डॉक्टर है गांव के पास उसी को बुलाते हैं खोटे नहीं ले जाते हैं सादा और जिसके पास पैसा नहीं लगता है वो लोग तो ले जाते हैं. आती है हर महीना आती है इस महीना भी आई थी और जिस दिन राशन दिए उस दिन धान काटने चल गई दूर में.
बीमारी के लिए गांव के अंदर कुछ है क्या सुविधा?
सुविधा अभी तो नहीं है गांव के अंदर.
Such delays can prove to be costly. Pneumonia in children under 5 often progresses rapidly. Delay in diagnosis and treatment can cause complications or even death, especially in newborns.
As you would notice, because the under 5 mortality in rural areas is higher, in absolute numbers, the number of children who will die of pneumonia in rural areas will be much, much higher. Families sometimes can't recognize it early enough, particularly when the babies are small, a 2-month-old baby or a month-old baby. They may have difficulty, so mothers need to be taught how to recognize pneumonia. Secondly, sometimes pneumonia spreads fast or it worsens fast, so people have to access treatment very quickly. And this is a problem for urban poor, it is a problem in rural areas that they can't access medical care in an evening, in the middle of the night, transport, referral, those issues are important. Third, early treatment through ASHAs and ANMs is still not in practice effective.
Once a mother has taken a baby, a child with fast breathing, cough, not looking well, to a health worker, private or public, the right things have to follow. Namely, some of these children have to be treated in the community. They can be treated with oral antibiotics, and that doesn't happen. Some of them have to be taken to a facility, which may be a distant facility, and that doesn't happen.
When Lakshmani was brought to the hospital, she was critical. Her lungs were impaired.
This child is 10 months old. When a child came to this hospital, had a history of fever for last 10 days and has respiratory difficulty. Better treatment initiated initially if detected early, and treatment started initially, given antibiotic, then that child will not reach in that state.
In rural India, healthcare is far away from home. Respiratory illnesses are often not detected on time, resulting in high mortality.
Initially, not treatment started by doctor and not recognized early. So, the child was kept at home for a long period, and when child becomes serious, not taking feeds and fast breathing, then attendant reached here. Because of lack of medical facility, they have to come to travel long distance for reaching peripheral health services and other medical facility.
Easy to treat with antibiotics, pediatricians say frontline health workers need to be trained to provide point-of-care service. Auxiliary nurse midwives and even ashas who live in the village itself can give first-line drugs to children and save thousands of lives.
There may be a issue here of treatment having to be modulated somewhat, and so medical attention is very important. And then severe malnutrition, micronutrient deficiency, like zinc deficiency, indoor pollution, all these either increase the risk of pneumonia or increase the likelihood of pneumonia becoming worse. And so these basic issues have to be tackled. Then we have to ensure that supply of antibiotics in primary health centers, sub-centers, at ICDS centers and with ASHAs, that supply is all year round and not episodic, and there are still gaps in the supply area. We need large number of patients are going to private sector and coax. We need to engage with this issue. And the best way to do is to make ASHAs an attractive service provider, make A&Ms attractive and effective service providers so that the dependence on the private sector is less.
If you look at the antibiotic usage in pneumonia, it's something like 15%, 13%. Doesn't seem to be changing very much. So appropriate treatment does not happen. That flow does not happen, and I think that is the point. Therefore, having greater amount and number of opportunities, closer homes where the children live is the way forward.
Ignorance costs lives in cities as well. Few mothers can recognize the symptoms of pneumonia. Rithamba's 21-day-old son had high fever, was breathing fast and had stopped feeding. Visits to doctors didn't help much. The physicians ignored vital signs and misdiagnosed his condition as routine fever and cough.
இந்த மாசத்துல 3 ஆயிட்டு ஹாஸ்பிடல் போயாச்சு. என்னதான் பிரச்சனை? ஒண்ணும் இல்ல, சளி தான் பிடிச்சிட்டு இருக்கு. இல்ல அதெல்லாம் இல்ல, சளி தான் பிடிச்சிருக்குது. நேத்து கூட ஆஸ்பத்திரிக்கு போனோம். அதெல்லாம் கேக்குறாங்க, என்ன சொல்றது?
4-5 दिन बीमार रहता ना, उसको इधर इधर लेके चले गए. उसके बाद में 4-5 दिन पहले उसके बाद में दूध कुछ पिलेगी नहीं. उसके बाद में हॉस्पिटल लेके चले गए, मेडिकल हॉस्पिटल सामने है ना, वो लेके चले गए, खत्म.
Rajni's 7-month child was fortunate. For over a month, he struggled with pneumonia, but it was not detected. It was only when he turned blue, a sign that the infection had entered an acute stage, that his father took him to a tertiary care hospital just in time. He recovered but has fever once again.
इसको पहले बुखार आया, उसके बाद खांसी जुकाम हुआ.
तो उस वक्त आपने क्या किया?
इसको सिर्फ मैं कुछ नहीं करती थी, तब मुझे पता नहीं था. ऐसे ही मौसम के कारण से इसको लग रहा था कि उस टाइम बारिश भी हो रही थी, ठंडा गरम हो रही थी, तब उसके कारण से इसको हुआ जैसे लग रहा था मुझे. तो मैंने डॉक्टर को भी नहीं दिखाया, तो ऐसे ही सरसों के तेल से ही मालिश करती थी इसको. फिर 2 दिन के बाद मैंने थोड़ा बुखार और खांसी तेज़ होने लगा, तब मैंने इसको दिखाया. फिर उन्होंने दवाई दी, तो दवाई से ठीक नहीं हुआ. उसके बाद में एक ही दिन में इसका तबीयत ज़्यादा बिगड़ गया. तो इसका धड़कन जो है प्लस सांस तेज धड़कने लगता था. ऊपर नीचे जल्दी होने लगता, जोर से.
The experience has not changed anything. The child continues to remain at risk.
अभी तो पूरी ठीक हो गई, तो इस कारण से दवाई 5 दिन के लिए दिए हुए थे, तो दवाई 5 दिन दिए, उसके बाद ठीक हो गया ये खाना.
तो अब गए थे क्या दोबारा?
अभी नहीं गए हैं.
आज मुझे 6 दिन हो गए हैं. इसको सांस बहुत तेज चलते थे,
रात में तो दूध नहीं पिया, मैं सुबह लेके 6 बजे भागी आई हूँ यहाँ पे।
आपको क्या लगा उस वक्त? कुछ बीमारी है?
मुझे कुछ ये लगा कि मतलब बहुत तेज़ सांस चल रही है, इतनी तेज़ नहीं चलनी चाहिए और ख़तरे से बाहर लग रही थी मुझे, इसलिए ज़्यादा।
For a normal child of this age, it must be 50. It's around 44, fine. But now he's on oxygen. So this is pulse oximeter, which will check the baby's oxygen level and the heart rate. So the upper one is the oxygen level and the lower one is the heart rate. The normal heart rate will be 120 to 130 for the child. So now I am removing the oxygen. I am actually going to assess whether the child needs oxygen or not. So I am closing it down and I am removing the oxygen. This is the retraction. The lower chest will go in when the child breathes in. Actually, the lower chest will go out when the child breathes in. So, when the lower chest goes in when the child breathes in, that is called retraction. That is a sign of pneumonia.
Pneumonia is the single most important cause of under 5 child mortality, and we introduced the community and facility based approach to reducing pneumonia deaths way back in early 90s, and it is based on elegant work which WHO conducted in different countries. So good algorithms are made, referral criteria is laid down, specific treatments have been laid down. I think we failed because we failed to scale up well designed interventions and take it to a level where it would be responsible for reducing much of the pneumonia related mortality. Reduction in pneumonia mortality is within our grasp because we know what works. We have those medications and drugs available in our supply chain. But I think the emphasis on pneumonia related issues in the RCH2, RCH1 and also in NRHM to an extent has been somewhat low, and therefore it did not get the attention and the momentum and increasing momentum that would have been expected in this regard has been absent, and we need to address that issue now upfront.